Hello, everyone. Good afternoon. Welcome to this launch of Dean's Grand Rounds. I'm delighted that this ambitious project, which is one of the key planks of our Dean Subodh's priorities of translating education into good practice. I'm really grateful to Professor Sinclair and the colleagues at Addiction Faculty and Dr. Mohammed Gul and colleagues from the West Midlands Faculty for taking up the challenge of being the first one to organize the first grand rounds of this series. On a topic which I'm sure all of you would agree is very close to all of us, which is proved from the enormous response we had for this webinar. As Julia always says, addiction is everyone's business. It's not particular to any subspecialty. And I'm particularly grateful to Gemma, who I would say that the most important voice of this afternoon. I think we always need to hear from our service users and carers. As you would see, you might have seen for the program, we have a very packed 1 hour and a half. So it's really important that all these speakers keep to time. So we'll kick off with our Dean, Professor Subodh, telling us about his ambitious vision. And then we'll move on to Professor Julia Sinclair to set the scene. And then we will move on to Professor Gemma talking to Dr. Ed Day. This just to bring the real clinical issues into focus. And then Dr. Zafar Iqbal will help us to see this from a public health perspective. And then again, Professor Julia Sinclair will share the POMH data. And then the NATRO will share some local data from Birmingham. And before we move on to Dr. Deepa Bagepalli and Alina Braicu will sort of tell us about how this can be translated into a QI project, which will make a real difference in the care we provide for our patients. And then I really hope that we'll have some time left for discussions at the end. And in the panel, we'll be also joined by the Renarta, Rowe, Kerry, Webb, and Rowena Jones. So I'm grateful to all of you, and particularly the Calc team who worked in the background, despite being so busy with the International Congress, which is due to start on Monday, and Dr. Deepa Bagepalli, who's been really helpful in coordinating and to making this a reality and helping us to launch this on time. So thank you very much. So Professor Subodh, over to you.
Thank you so much, Raoof. And a warm welcome. And I think, and I say warm, it is warm, isn't it? I don't know where you are, whether it's really warm where you are, but I'm definitely enjoying my linen shirt today. So a warm welcome to everyone. I know we have some international delegates as well. So wherever you are, hopefully it's a good time. I want to share a little bit of the background as to why the Dean's Grand Rounds. And I think, we all know, hopefully we all know that actually when we talk of applying evidence to practice, translating evidence to practice, sadly, there is a gap of almost 15 to 20 years, sometimes that takes place. And I think we've seen that with, we don't need to look too far. I think we know, for example, that smoking cessation would be one big, has the largest effect size in terms of reducing the mortality gap for our patients. And yet we've known that finding for at least 2 decades. And I don't think that we've been able to make a dent in the lifespan of many of our patients with severe mental illness. And similarly, today's topic, I think, is great. I won't kind of give the whole thing away, but I think, addiction, substance misuse as a whole is so important. So I'm glad that we are starting our inaugural grand rounds with this idea as to how do we translate evidence into practice, and beginning with something in the field of addictions is absolutely fantastic. I think I've been humbled by the amount of work that Julia, you and your team have put in, not just in this grand rounds, but over the last few years in terms of putting addictions right at the heart of our training. And I think I really want to emphasize that, because substance misuse comorbidity is such an important element, that we all see clinically. To not have that as an integral part of our training would be an absolute travesty, and not just for our training, but for the outcomes of our patients. So the idea behind the grand round is quite simple. It's really about making sure that our education offer, our training offer, our journal clubs are really relevant to the outcomes, health outcomes of our patients, and not just of our individual patients, but for the communities of practice, so for the communities where we practice, and how do we make that happen? And so for me, I think it was really about bringing in those 4 key elements, which you've probably seen me talk about and write about, and it's in the write-up of the grand rounds. But again, reminding you, it's a lived experience, and again, very, very grateful that that's how, that we have that today. So thank you very much. The academic evidence, again, that's coming straight from the faculty, and the third element of the public health element. So how does that gap in evidence play out when you start thinking at the population level? What is the impact of that? And the fourth critical element, I think that's where I think the college is going to play a big role, I think, by supporting how do we start using quality improvement measures to start making a dent in that gap? How do we start narrowing that gap between evidence and practice? And I can see already some thoughts around, ideas as to what should happen. So thank you again. And Raoof, I'm going to join in and listen now. So thank you for inviting me.
Thank you very much, Subodh. That's great. And also, just to remind everyone, you can use the chat box to comments and interacting with other attendees. And after the webinar, you'll be sent the details of how to watch the recording, and certificate of attendance will be emailed to you. And also, of course, then don't forget to fill in your feedback, because we really want to improve this as we go along. And already I can see some Twitter chat about various other clinical matters members would like to be addressed, which we will do. Okay, without further ado, let me hand over to Professor Julia Sinclair.
Thank you very much, Raoof. And my video, there we go, is now about to start. So thank you very much. Thank you for that great introduction, and welcome everybody. In terms of getting involvement, I've got a quick thing for everybody to vote on. So if we could just have our first poll now. So how confident do you feel in the management of alcohol withdrawal? So you've got a choice there. You can be very confident, reasonably confident, or not very confident. So if we just have a few seconds while people kind of choose that, just to kind of situate where we are as professionals with this. And then I'll go on to setting a little bit about the rest of the context for today. Okay, so hopefully everybody is able to fill that in. We'll just leave it up for a few more seconds. I know quite a few people are still arriving, and consequently maybe trying to sort that out rather than do the poll. But if we just leave it for about 10 more seconds, and then if we could show the results, please. Marvellous. Thank you very much indeed. So of the people who voted, 313, 15% of you felt that actually you were very confident, 62%, so almost 2/3 thought reasonably confident, and almost a quarter not very confident. So firstly, thank you for sharing that, because I think that is part of the really important reason why we're all here today. And so thank you for coming. Next slide, please. Why do I think that every psychiatrist needs to know about this? And the challenge that I would have really for all of us is that as psychiatrists, we really need to reclaim alcohol use disorders, alcohol dependence, primarily as a mental disorder. Obviously, it has many other aspects to it at all. But in order to do that, we need to really genuinely embrace person-centered care rather than thinking of alcohol dependence and addictions more broadly as something that is other to core mental health work. Next slide, please. This has been sort of enshrined really in so many of the policy documents and that we've had over the last decade or so, the concept about it being everybody's job, no wrong door, and within the long-term plan, as far as transformation of mental health services go, actually the inclusion and management of substance use disorders is actively included within the NHS long-term plan. Next slide, please. But why isn't that happening? I think there's a big thing around confidence and competence. So as colleagues have shown who are here just now, I think a lot of people perhaps don't feel particularly confident in management. And partly that's because it's nowhere really in our curriculum. And so this is part of this kind of introduction. Back in 2012, I was privileged to lead some work that was combined between the Royal College of Psychiatrists and the Academy of Medical Royal Colleges to look at alcohol and other drugs and the core medical competencies, no matter what specialty you're in, be that surgery, medicine, general practice, psychiatry, child health, etc. It was signed off by all of those colleges, and we came up with 12 competencies that we thought actually every doctor needed to know in order to really ensure that this holistic patient-centered care could actually happen. Next slide, please. Of those 12 competencies, I'm not going to go through them, but I just want to highlight 6 of them here. The fact that we actually know what the effects, common presentations, and potential for harm of alcohol and other drugs are, that we're able to be competent to make an assessment, and this will come up later, that we can recognize the wide range of both acute and long-term presentations that involve use of alcohol and other drugs, and particularly for us in psychiatry around trauma, depression, as well as other physical health complications, to be able to provide brief advice on use of alcohol. I always say that's just a clinical conversation, there's nothing magic about it. And to be able to provide management, in for today's case, of alcohol withdrawal or referral where is appropriate. And just more broadly, feeling confident and comfortable discussing alcohol and other drug use with patients. Next slide, please. So kind of 10 years passed, you know, that hadn't particularly been progressed. And in the meantime, we'd had a reduction in terms of specialist places, numbers of people becoming consultants. The Health and Social Care Act kind of resulted in this further divide between addiction and mental health services. And so in 2018, we were commissioned by the Health Education England to look at what the current challenges were and what the recommendations were. And I'm very grateful to my colleague Louise Sell for leading this work and publishing this report, which I'd really recommend to those of you who haven't read it yet. It's on the college website. So what does it say? In terms of, next slide, please, in terms of the main recommendation was around this fact that addiction psychiatry, we have fewer structural safeguards to maintain training numbers than is in the case for other specialties. And so we made the suggestion that rather like in psychotherapy, that we establish a requirement in the curriculum for psychiatry that all trainees progressing from core training actually have to complete 2 workplace-based assessments, the assessment and longitudinal follow-up for patients with addiction disorders. And we would support that. So next slide, please. In terms of progress to date, it was approved by the college in 2019. And then it got into the final curriculum approved by the GMC, which was that there is a requirement that all core trainees must demonstrate skills in assessing and managing patients with addiction. And this goes live in 2022. What that means is that not every psychiatry trainee has to do an addictions post, but what it does mean is that every trainee needs to recognize, assess, and manage comorbid addiction in the areas where it presents. And we know it presents within adult mental health, within CAMS, within older person's mental health, perinatal liaison, etc., etc. And so I'm really pleased that this is happening. And this, I think, is part of the context for why actually our trainees and hopefully then educating us will help us in terms of delivering on this. Next slide, please. So we've, as part of this, developed an addiction tutor network, and this is to facilitate all trainees to have access to suitably trained addiction specialists to help them in completing that workplace-based assessments. We're developing this regionally in order to help our directors of medical education locally to deliver on this requirement, and we're going to probably integrate it to structures that are currently there regionally. We're really, really clear for those of you trainees who are listening that this is an offer and not a threat for trainees. We want it to be a really positive experience. And we're launching this in the webinar on the 15th of July. And anybody who would like to be involved, please contact Catherine Squire. So that's the background. I want to pass over now to my colleague, Dr. Ed Day and Gemma, for the probably most important part of this webinar. Thank you, Ed and Gemma.
There we go. So, good afternoon, everyone. Welcome to the Costa del Solihull, where it's about 400 degrees in this room at the moment. I'm delighted I'm joined by Gemma, and we're going to have a brief conversation about. We've got about 10 minutes to which I think will demonstrate some of the points that we're trying to get at in this webinar today. So thank you so much, Gemma, for joining us. It's really kind of you to give us your time. I wonder if you could just tell us a bit about your relationship with alcohol.
So I started drinking in my teenage years, really, and it started out as just social, and developed over time. I perhaps didn't know that there was an issue until my early 20s, but for me it wasn't so much of an issue then. Because it was manageable. I sort of had something going on in the back of my mind that this is going to be a problem, but it's not, so I'm not going to deal with it. So I didn't do anything about that, you know, the way I saw it. I was holding down a job, I was having fun. I did have children at that point as well. Anything that I would have thought about doing, perhaps I wouldn't have, perhaps the threat of, you know, services getting involved at that point would have put me off anyway.
With your children?
Yeah. So it wasn't until I was 35 and physically dependent that I felt there was no other way to go than to stop. I wasn't very well mentally. Waking up every day was just horrific. You know, I was isolated, suffering with anxiety, depression, drinking to sleep and to stop the withdrawal, and drinking against your will, really, as well. Not wanting to, but having to. That was just, it was just awful. So that's where I was at 35, and
was there? Had you sought any help to do with the alcohol up until that point?
So I had bouts of depression, postnatal depression. I had my son at 18, and for a short time afterwards, you know, I was a young mom, and I struggled with my identity and responsibility, and was treated for postnatal depression. The drinking back then wasn't so much of an issue that I thought it was anyway,
Was it discussed at all?
I think every time I went to the GP, I was asked whether I drank and whether I smoked.
What did you say?
You know, and if you're a few units over, I felt like I was being judged. So I tended to downplay stuff a lot for the GP, and never seeing the same GP and trying to get that rapport with somebody or a bond with, you know, and being able to speak freely, perhaps had an impact. I was never offered any sort of counselling or anything for postnatal depression, or referred into any kind of services that help young mums. So just kind of left to get on with it, really.
Right.
Yeah.
And did you have treatment for the depression and anxiety? Did you have medication, or was?
I think I can't remember what medication it was. I did go on antidepressants, right, yeah, when I was about 18, 19. In my 30s, when I was suffering with severe anxiety and depression and isolation, they put me on sertraline, and I had propranolol.
Okay. So you had medication there. But what was it about in your mid-30s that made things change then? Why did the situation change?
So life had been pretty poor, really, for me. But at the age of 35, I had a baby at 24 weeks, and he didn't make it. 2 weeks later, he passed away. And from that, everything spiraled. I found it difficult to go out into the world and face people and talk to people, because everybody seemed to have a story that they wanted to tell you. And you know, I just sort of became more isolated and more comfortable in the home. But of course, that with that, my drinking stepped up a gear. It went from a few times a week to every night of the week, drinking to sleep, drinking to even have to go out and do some shopping, because the thought of seeing somebody, you know, would bring me out in sweats. And
Yeah.
So in the end, I was, like I say, physically dependent.
And so what happened then? How did you start the journey to doing something about that?
I had a bit of a sort of voice in my head that told me that I shouldn't be living like that. I had 2 teenage children as well. Obviously, it was affecting them. But to be honest, it was more about the fact that I couldn't continue the way that I was going. It was perhaps on the border of being suicidal or doing something about it. And my aunt came round to the house once, and I was in a bad way, you know, and I just said, I've got to do something. It's an emergency, or I'm not going to be here next week, you know. So we started to ring round rehabs, because that was all that I knew about.
That's what you thought treatment was, go to rehab. Yeah.
I didn't know about any services. Nothing had been suggested. I mean, it got to a point where I couldn't hide the fact that I was drinking anymore. So it must have been obvious to everybody. But you know, they wanted £10,000, and they wanted me to go to Scotland, and that's not going to happen. Although I did ring my mum and see if she had £10,000.
Yeah, she didn't. No.
And luckily enough, my mum had picked up a leaflet at one of her hospital appointments for SIAS, and that's where I ended up.
So that's the Solihull Integrated Addiction Service for people that don't know. So that's where we are now, where we're sitting now. Yeah. So what happened when you so you didn't know about this service, which is the local NHS statutory provision for treatment in your area? You didn't know about it.
I'm Solihull born and bred, and
okay.
And I didn't know.
But you came, and what happened when you came here? What's been the pathway then?
So I came here in a bad way, and I was allocated a key worker. Perhaps cried in every single one of my appointments. Just wanted somebody to tell me what to do and to fix it for me, you know. I wanted to stop drinking, and I wanted to stop drinking quickly.
Yeah.
I was told that I'd have to show some commitment in order to be offered a detox. Didn't know that was even going to be, you know, I didn't know how I was going to do it.
No.
I knew I wanted to stop, but I didn't know how.
Yeah. So you weren't aware that there was a thing called a detox?
No.
Where people gave you medication to help you come off the...
No, not at all. All I knew was that from the movies and from the TV that you know, people went to AA.
Yes.
And that was it. Didn't know about NA, didn't know about any sort of other mutual aid or support services. So I just wanted to come somewhere and for somebody to tell me how to stop.
Yeah. And cutting down wasn't an option for you?
No, not at all. No, I needed respite as well. I think, like I said, I had a 17-year-old at home and a 13-year-old at home. They probably needed a break from me, and I needed a break from them.
So what happened? You got that detox here?
I did, yeah. At the time, we had a facility. They had a facility that was called Clarity House, which was where I went in, and the nurses here came in every day and oversaw my detox.
Yeah. So you had a medicated detox, and then Clarity House was a sort of dry hab sort of rehab type place. So you stayed there.
Stayed there for 4 weeks, 28 days, and did group in the morning, group in the afternoon, and was taken to 3 or 4 mutual aid meetings a week, introduced to the recovery community, learned about myself and went over past traumas that I perhaps thought were boxed off, childhood stuff. Learned that, you know, my dad's an alcoholic, learned that it could be hereditary. And I think the most important thing that I learned was that it wasn't necessarily my fault. You know, I didn't know when I started drinking, doing what all my friends were doing, that I was going to end up a physically dependent alcoholic. You know,
and drinking was a way of coping.
Yeah.
In the early days.
Yeah.
So we're nearly at the end of our time. That's been absolutely blown by. But tell us what's happened then, or tell everyone what's happened then. How long ago was it that you did that detox?
13th of March 2018.
Right.
Yeah.
And it's important that you know that date. Yeah.
So that was my first day sober in 21 years. Well, in 4 years probably, but I've been drinking for 21 years before that. So yeah, I'm over 4 years sober now.
And what have you been? How have you maintained that sobriety? What have you been doing?
So mutual aid meetings, and although I was alcohol dependent, I chose to go down the NA route. For me personally, that was the best way to go. I like the fact that it looks as addiction as a whole. So I do that. I volunteered initially for 9 months with the changes.
So that's one of the peer-based charities that's part of this service.
Yeah.
So what did you do there? What was your role as a volunteer?
Peer support.
Right.
So I went away after I did the initial 4 weeks detox. I thought, let's just not get what it was a week detox, 3 weeks, then sort of respite and doing group work. And I thought, well, I've been doing this for 21 years. I need to do more. I need to learn more. So I went away and did an 8-week day program. And by that time, then I was 3 months sober and able to go back to Clarity House and take people through their detoxes.
Right.
Yeah, loved it. Absolutely loved it. And then after 9 months of volunteering, I got a job as a recovery coach working for Changes UK, based here at SciS. Yeah. So
bang on our 10 minutes. I think we'll stop there, Gemma, because thank you so much for doing that. But so what you started off this consultation with me in a doctor-patient relationship, and we finished up as colleagues, which is a perfect way to hand over, I think. And thank you so much for coming in and doing that for us.
Thank you.
Thank you very much, Gemma. That's really, really appreciated. And I can see the chat is full of people really thanking you for your your contribution. And everyone agrees that we can't really plan or deliver quality services without listening to individuals with the lived experience. Thank you, Ed. Thank you, Emma. Thank you on behalf of everyone. That is excellent. And now let's move on to Dr. Zafar Iqbal, who will give us a public health perspective on this. Over to you, Dr. Iqbal.
Hi, thank you very much, Dr. Raoof. Is it possible to have my first slide, please? For those of you who don't know me, you won't know me because I'm not a psychiatrist. I'm a public health consultant and I'm an associate medical director within Midlands Partnership NHS Foundation Trust, which provides a whole range of mental health and physical health services, and including addiction services as well. I'm also been a director of public health for about 10 years, and I'm currently on our Faculty Public Health Board. And I think, mental health and addiction are areas where I think, there is a lot of good joint work going on between the Royal College and the Faculty of Public Health, but I think we have so much common interest. I think we need to do a lot more work around this. Next slide, please. So from a public health perspective, I was asked to give a public health perspective and talk a little bit about data. So the kind of questions that I would be asking good place to start is what does the data say? What does the evidence say? Naturally, we're interested in the broader influences on health, as we know that health services account for a relatively small proportion of the overall impact on our health outcomes, and what really matters at the end of the day is the kind of social environment, the housing, education, deprivation. Those kind of issues are really, really important factors in influencing a patient's health, and they apply as well to mental health as to anything else. Really important to understand who gets treatment and who doesn't get treatment. Who are the people who are not actually accessing treatment? How can we reach them? What can we do about prevention? Are we scaling up prevention? Are we, how do we have a system-wide approach? And the relationship with inequality is really interesting, and I'll come back to that. Thank you. Next slide, please. From a public health angle, it's incredibly complicated to unravel this. There's a whole number of factors which influence outcomes, whether it's short-term outcomes, long-term, mortality, or the harm to others, the harm to society. There's a range of societal factors, from pricing to regulation, and the context that people are drinking and the culture that we create around drinking. That's so important. And socioeconomic status, which I'll come back to. Individual factors, age, gender, homelessness, mental health, and I'll come back to mental health as well. So it's a really complicated situation. Next slide, please. Again, this won't be a surprise to you. It is the biggest risk factor for 15 to 49-year-olds in terms of ill health and disability. Over 1 million people with alcohol dependence. And it's really interesting to see that only a tiny proportion, 4% of the population, consume around 30% of all the alcohol sold. So it's that bell curve, and it's that extreme end of it, really. And the harm, physical harm caused by alcohol, is a major, major contributor to the inequalities we see in mortality and hospital admissions. Mental health, I'll come back to in a bit as well. Next slide, please. So I was a director of public health in Stoke-on-Trent, which, for those of you who don't know where that is, it's quite a deprived area in Staffordshire, north of in the North Midlands. And one of the things that I found there was that our outcomes were really, really poor. We had really high levels of alcohol mortality. We had really high levels of admission rates, but that wasn't reflected in the levels of drinking, which were above average, but they weren't the worst. And yet our outcomes were the worst. And at that time, I think we were beginning to unravel some of this, and we didn't quite understand the association between the levels of deprivation and the impact that has on outcomes. And I think now we understand it a little bit better. It's about patterns of drinking, but I think there's a lot more work to be done. And just by living in deprived areas, that has a really big impact on our outcomes, which is beyond the level of drinking that people have. Next slide, please. So in terms of data, I think it's really important that we understand our patient population, and also understand where they're coming from, what our local communities look like. I know as a psychiatrist, the most important thing will be the patient in front of you, but I think it's really important that we do understand the wider social context. And there's a whole range of rich data which can easily access through fingertips and other sources, which can give you quite a good profile of what the deprivation scores are, what's happening to children, what's happening to homelessness, what's happening to violence, domestic abuse, and employment, a whole range of factors which influence alcohol. And you can see how these indicators vary between place to place, and whether we're above or below. I think all these things help you to build a picture of what kind of community our patients are coming from, which enables us to then give better services. Next slide, please. As well as kind of social determinant type of data, really powerful, rich data on outcomes, whether it's hospital admissions or whether it's mortality, whether it's age, sex, specific mortality, and you can see trends that are happening as well. Next slide, please. I think comparison is really important, so you can compare not only within, for example, I mean, I live in the West Midlands, I work in the West Midlands, but you can also compare with similar, so if you work in, say, Shropshire or work in Herefordshire, you can actually compare with similar types of local authorities or populations. So there's lots of different ways of cutting this, and you can see how far out you are with a whole range of indicators. Next slide, please. So coming back to kind of mental health, we know there's a strong relationship between mental health and alcohol. An estimated 44% of community mental health patients have reported a problem drug use or harmful alcohol in the previous year. Large number of people sort of affected with mental health and alcohol, and a whole range of disorders from anxiety, depression, sleep problems, psychosis, bipolar. Really powerful connection between mental health and alcohol, and also suicides, where there's a graph there where sort of 10% of all deaths by suicide are, again, there's an alcohol component underlying that. Next slide, please. As well as looking at the social determinants and the outcomes, you can also look at how well your particular service is doing. I think it's important to keep a track of that, especially when you're looking at QI type of initiatives, and to have a look at if your service is an outlier, how can it improve? How can it improve some of these outcomes? Whether you agree with these indicators or not is actually less important. It does give you a basis to develop QI initiatives. Next slide, please. So coming back to kind of, what can we do about it? I think in terms of public health solutions, at the local level, it's about zoning, it's about licensing, it's about trying to reduce some of the health inequalities. And I think that it'd be really good if you could make maybe links with your local public health department. I think there are, common interests. It's the interest of psychiatrists as well as public health specialists to be able to address some of the health inequalities, to reduce some of the massive burden of illness caused by alcohol, and actually get some of the get at some of the underlying root causes. I think it's really important that we have advocacy to have scaling up brief interventions, which can be effective, whether not just in primary care, but a whole range of other services where, where we have an opportunity to be able to, ask very simple questions and can provide some brief advice. I'm really disappointed that over the last 5-10 years, we've seen a reduction in alcohol, relative reduction in alcohol funding. And that's not because of, we wanted to within the kind of public health departments. That's because the funding just hasn't been there. I think I'm more optimistic. I think there is now funding coming on board, which is really well needed. Obviously, focus on evidence. I would say that as a public health doctor, and there's a whole range of nice guidance around mental illness and substance misuse. So my kind of final kind of point is really, get to know your public health department, get to know your local profiles, and understand your local communities. And I think, we need to work together with public health colleagues and psychiatrists on our common interests. Thank you very much. I'll leave it there. Happy to take any questions.
Thank you very much indeed, Dr. Iqbal. And there'll be questions there. And also please do post questions in the chat, and we can answer those as well. Could I have my slides up? Sorry, I seem to have got muted. Hopefully I'm back online now. I want to move on from the public health perspective and to move on to what we're doing within psychiatry and mental health services more broadly. And I want to present some data from the Prescribing Observatory for Mental Health, which many of you will be familiar with, those based within the UK. And it comes from the college's Centre for Quality Improvement. It undertakes a range of national benchmarking audits around prescribing. And in 2014, the first one based on the NICE quality standard for alcohol use disorders. So that was based on the clinical guideline number 100, which was the one done by the Royal College of Physicians, as well as the one which was supported by the Royal College of Psychiatrists about the management of alcohol use disorders. And it aimed to look at medically assisted withdrawal in patients who were admitted to either an acute adult or a psychiatric intensive care unit within mental health services. So there was a baseline audit undertaking in 2014, the re-audit in 2016, and then a further audit again in 2021. And the difference between those was that in 2021, we also involved the 4 remaining inpatient units, which still offer addiction services within the NHS. And I'm delighted that Dr. Watts is here with us and can also hopefully answer some questions. In terms of participation overall, 43 mental health trusts participated. That's 177 clinical teams. There was over 1,000 participants in each wave. And the key thing is that, you know, the vast majority of these inpatient detoxes are actually overseen by a non-specialist adult psychiatrist. Next slide, please. The key findings from the re-audit, I just want to start with that before I present the data from 2021, was that, you know, the majority of these are unplanned. Patients come into hospital for another need, and as part of that, they then need to actually be medically withdrawn from alcohol as part of their acute inpatient treatment. And as you can see there, the vast majority took place in a non-specialist setting. The next thing, and I think this is a really important thing, is that overall, 1/5 of these were the first known detox. So there's a real opportunity to make a difference. If we get this right, if we start this pathway off right, somebody's come in, they've come in for psychiatric admission, and it's their first ever detox. So that if we can get that right and that part of the pathway, we could really improve things. But what was shown in 2016 was that at the initial assessment, based on the NICE quality standards, which I'll show you in a minute, actually 20% of patients had no documented alcohol history. And these aren't all patients, just to reiterate that because the way that the audit's undertaken, it's based on the patients who are identified during the audit period as having had, so retrospectively, the requirement for medically assisted detox. So we're already starting with a group of patients who have been recognized and detoxified from alcohol. And in those patients who'd been started on a detox, actually 20% of them had no documented alcohol history. 15% had had none of the recommended bloods taken. 1/3 had no documentation of any of the signs of Wernicke-Korsakoff syndrome, and almost 1/2 had not had any documented use of standardized assessment tools, such as the withdrawal scale, which is the CWAR, which enables you to objectively measure levels of alcohol withdrawal, the severity of alcohol dependence questionnaire, which kind of give you an idea of how much medication you perhaps need to start people on, or the audit, which kind of is a broader screening tool for alcohol dependence. So there was also kind of evidence that actually patients were much less likely to get evidence-based interventions if it was managed by a non-specialist, and specifically really around relapse prevention medication, which was given to just under 1/2 of patients in patients managed by specialists, but only 14% in those with non-specialists. Next slide, please. So these next slides are taken directly from the POMH presentation, and I'm very grateful to Professor Thomas Barnes and Carol Payton and the CCQI team for allowing me to share these. And for those of you who've been involved at a trust level, you will have copies of these slides and where your specific trust actually fits within that, but I'll obviously just be showing the national data. Next slide, please. As you saw on the last one, the data was collected during 2021. So obviously that had an impact in terms of the fact that there was the pandemic. This had a number of impacts in terms of potentially, say, using breathalyzers, clinical staff, the ability to undertake physical examinations and blood samples. And so what I've done in this presentation is I've not particularly focused on those quality standards so that we can have a clearer idea of some of the broader aspects of the management of alcohol dependence. Next slide, please. So in terms of the practice standards, there were 5 practice standards and 3 treatment targets. And so the 3 practice standards that I'm going to focus on here is about the fact that the decision to undertake alcohol detox in an inpatient should be informed by a documented assessment of how much they are drinking and their current alcohol intake. Pharmacotherapy to treat the symptoms of acute alcohol withdrawal should be limited to a benzodiazepine or carbamazepine or clomethazole. This is a quality standard that's quite old now, is in the process of being updated. So on the whole, we'd say probably a benzodiazepine, and that thiamine should be prescribed parenterally for all inpatients in acute alcohol withdrawal. Next slide, please. In terms of the treatment targets, the 2 that I'm going to focus on is that the following alcohol detox, initiation of relapse prevention medication should be considered, and that after alcohol detox, referral to a specialist alcohol service for ongoing management and support should be considered. So a detox is very much part of the pathway. It's not a treatment in itself. Next slide, please. So in terms of the method, as I said earlier, it's any patient who'd been admitted to an acute adult or psychiatric intensive care ward, or in 2021, a specialist inpatient drug or alcohol unit who underwent an alcohol detox whilst an inpatient. So these were patients that from the notes you could identify had actually undergone one. And there's the data collected. 45 trusts submitted data for this audit that involved 173 clinical teams, and data that I'm going to show you the summary of is based on over 1,255 patients using the POM-H data collection tool. Next slide, please. So what you can see here and how I'm going to present this is that in answer to the specific questions, what we can see here is the standard is either met if it's in green or not met if it's in red. And I can show you for completeness the responses in 2014, 2016, 2021. And then for 2021 itself, you've got the responses from the specialist alcohol units. Obviously, they're seeing a different set of patients, so we're not saying that these are going to be equivalent patients, but I think it's interesting data. The numbers that you can see in these bars represent the number of patients in each of those parts of the bars. So you can see in this first one for 2021 that 592 patients kind of met the, had a documented assessment of their drinking history, whereas 316 didn't. And that represents just over 60% of people who had a documented assessment. Next slide, please. So this is one for which I'm showing it as trust level data, because that's the only part that I have it as. So what this shows you is these are individual trusts along the bottom here. Each of them has their own number. And so if you're part of that trust, you know what the number is, but obviously if you're not, you don't. But what you can see from here is in green, this means that essentially a full assessment of the signs and symptoms of Wernicke's encephalopathy had been documented. If it's in orange, there was some, so a partial. And if it was red, it meant there was absolutely no assessment at all of whether the patient might have Wernicke's encephalopathy. So you can see overall, it's about getting on for just over 40% where there was no assessment at all, about another 30%, 25% where there was partial, and 25% where there was a good overall assessment. Next slide, please. So in terms of the proportion of patients prescribed benzodiazepine, this now just looking at the 2021 data. So in acute adult services, about 70% were prescribed one benzodiazepine, and that was much higher in the specialist alcohol services, although they are likely to have had the more complex alcohol withdrawal patients. So there is something here about polypharmacy, which needs some thinking of, but not necessarily the focus of this particular webinar. Next slide, please. This is the proportion of patients prescribed thiamine. And so in green, these are patients who've been presented parenteral thiamine. In orange, oral thiamine, which we know is not as effective in terms of reaching the central nervous system where it needs to have its effect. And red means that no thiamine was given at all, or there's no evidence that it was. And again, you can see the slight decline over the years of patients who, almost 60% back in 2014 got some kind of parenteral thiamine, and then that's reduced to just over 40% in 2021. Next slide, please. In terms of the next treatment target, the NICE guidelines would say that following alcohol detoxification, initiation of relapse prevention medication should be considered. That doesn't mean to say it's suitable for everybody, but it should be considered. And what you can see here is these are the main relapse prevention medications that people may be put on. Acamprosate, naltrexone are the first line treatments recommended by NICE. Disulfiram is second or third line. Baclofen does not have a licensed indication in this country, but is used in some places off-label. So we collected data on that. And again, what you can see here is that in terms of being prescribed medication at time of discharge from hospital for relapse prevention, actually 87% of patients managed by acute adult services were not prescribed any relapse prevention medications, and only 32% were not prescribed from the specialist services, which might be a nearer benchmark around people who might benefit from them. Next slide, please. Referral for patients for continuing management of alcohol use disorders. The ones I've highlighted again in orange are the ones that are perhaps kind of clearest. So, were patients kind of referred for continuation of care or by the mental health terms, so this idea of holistic care, managing within it, and about 27, so just over a quarter of patients continue to have their management within mental health services. As we might expect, that was much lower in the specialist alcohol units because they tend to refer patients back to the areas from which they came. So looking at the adult acute services in terms of continuing care provided by a dual diagnosis worker, that happened in less than 10% of time, and no clear plans to address future alcohol use was in about 0.25%. And that could be seen perhaps as a missed opportunity to kind of really make the most of the detox. Next slide, please. Then this is looking at referral of patients for continuing management. I won't focus on this one. Next slide, please. So in terms of the limitations of this, obviously it's an audit. So it starts with those people who are already identified as requiring medically assisted withdrawal. So we're only focusing on that. There's nothing on screening or identification, which we're going to talk about more from a QI point of view. The data collection period was 2021, and that was a strange year. And obviously, as always with retrospective audits, it's only based on documentation. But as we know medically, if it was not documented, it didn't happen. So next slide, please. I think in summary, therefore, what these kind of, data show us is that within acute mental health services, approximately a third of patients who are identified as needing medically assisted withdrawal had no assessment of their current alcohol use at the last audit. The documentation of Wernicke signs and symptoms was really suboptimal. Less than 50% of patients were prescribed parenteral thiamine, and 24%, a quarter, had no plans for management post-discharge, and 87% were not prescribed any relapse prevention medication. So I'll leave it there. Thank you very much.
Yeah, thank you, Julia. That's really helpful. I think we heard from Gemma the lived experience, and we had 2 presentations on the evidence and potential problems and possible interventions from at the population level and also at individual level. Now let's move on to the Birmingham experience. Dr. Rowe and colleagues, over to you, Nat.
Hi there, thank you. And I'm here with my colleagues Kerry and Dr. Rowena Jones as well. And I think we'll take some questions at the end. So next slide, please. So we've just got a few minutes really just to give you a whistle-stop tour of what we've been trying to do in Birmingham over the last 2 or 3 years. The reasons that we've tried really hard is because in my role as Deputy Medical Director for Quality and Safety, so many of our serious incident reviews, mortality case note reviews, complaints all relate to some kind of aspect of substance misuse. So it affects pretty much every clinical team, and yet it didn't really sit anywhere in terms of our strategic approach to this. We also had lots of feedback from our nurses, staff in inpatient wards in particular, in the postgraduate doctors in training and other staff. And that was very much about not only about competence, but confidence, which I think are two really important aspects to this. Lots of feedback from service users and their families, and we've obviously heard from Gemma, which was just such an inspiring journey, isn't it? So if Gemma's made that really significant transition in her life, surely we can all come together to do better as well. I think we need to take inspiration from Gemma. We also have data from our physical health committee about the screening and also managing the physical health problems, and also from our restrictive practice collaborative. So we know that in inpatient settings, lots of the time, restrictive practices are used in issues of conflict because people are maybe detoxing, but they're not being recognised, and therefore they're actually being managed in a probably not the most appropriate way, just because people haven't thought to ask those questions. So there were lots and lots of reasons why we felt we really needed to look at this problem in a slightly different way. Next slide, please. So in terms of the challenges, we've obviously heard some of them already through this session, but there's really something about competence in non-addiction services. We know that when those of us who trained quite a long time ago, it was an absolutely key part, and it's just kind of been whittled down and whittled down. So even if the competencies are there, people haven't done it for a really long time, they don't do it all the time, and therefore they're not confident. And I think that goes for nursing staff, probably even more than medical staff. And it's really then very difficult if you're in quite a challenging situation to, even if you feel that you've got the competency, you don't feel confident and you don't really know who to ask. There's also something about the formal training. So it's fantastic that I think this is now back in the competencies and being sort of taken forward in a much more robust way. And also how we share these experiences. So we've got processes in terms of learning once things have happened, but it's very important, I think, to try and get that a little bit more upstream, and also to share really good practice as well. The other really significant challenge in Birmingham, Solihull, and I would guess around the country, is the whole commissioning pathway and how the different services link to each other. So we have SIAS that Ed mentioned earlier. We've got one other service under our trust, but apart from that, we have to link with other agencies. And sometimes those referral pathways are really complicated. People don't know what they don't know, and therefore those really smooth transitions don't happen. And then I guess the third area is around that physical healthcare, and we know that physical healthcare is incredibly important in mental health services, but it's really difficult to actually make that happen sometimes, whether it's an inpatient or probably more commonly as an outpatient. And we know that there are lots of challenges for service users actually accessing healthcare for all sorts of different reasons. Next slide, please. So over the last, I think, 3 years or so, we've tried really hard. We've limped on through the pandemic. We've got a group of really focused and committed subject matter experts, but other colleagues as well, who have kind of joined us along on the journey. Firstly, to kind of think about the issues. So what are the problems? What are the challenges? How are we going to break that down? And we've used focus groups. We've used quantitative data. We've used qualitative data. We've been part of the POM audits as well. And we've used all of that to construct a driver diagram to just understand lots and lots of the different primary and secondary drivers, with then some change ideas. And some of those are, for example, scoping out the pathways. So we know, some people know some bits of the pathway, but probably nobody knows all of it. So we've done a lot of work scoping out, working with CGL, who's our local provider, and other providers, working out what's actually available and then communicating that, but also more importantly, working out what the gaps are so that we can link in with Public Health England to say, look, actually, this isn't maybe what's most beneficial, and what would good look like in the future. Next slide, please. So these are really the sort of different domains of our current plan and our next steps. And it's absolutely a work in progress. We haven't solved this at all, which is why we're so keen to link in with everybody here. We have really good clinical guidelines that Ed and colleagues have been involved in. So we're fantastic guidelines, trying to get them out there so that people know where they are and then feel competent and confident to use them is something that we're working on. Training not only for medical staff, but for nursing staff and other staff as well, and how we can do that in the midst of all the post-COVID stuff going on. I've talked a little bit about scoping pathways, and we've already made really good links. And you know, our colleagues are just as enthusiastic in making links with us as well, which is fantastic. Continuing that learning and making sure that where we've got that learning, whether it's good or not so good, we really share that and we really make the most of that learning. Absolutely listening to what the people that are actually experiencing these services say about it, and capturing things when things go well, but also really listening when they don't go well. We then want to move towards a kind of a written down strategy, not only for our trust, but for the system, because in terms of the ICS going forward and Public Health England, we're all in it together, whether it's the criminal justice system, whether it's social care, we've all got a part to play. And then finally, which links on to the next session, I think QI methodology lends itself really, really well to this because it's a really tricky problem. But having that framework, I think people can then use that as a bit of a blueprint to use that in their own clinical teams and real life settings. So I'll stop there. Thank you very much. But as I say, we're around for questions, I think, at the end.
Yeah, thank you. That's really helpful. That's just the scene. And also you mentioned there about the QI. Sometimes these problems, they may appear too complex and too difficult. It's really important that we are able to break that down and use a well-established methodology to makes even small, some little changes locally. So Deepa will tell us about that. Over to you, Deepa and Alina.
Thank you, Rao. So I think we've just had some really interesting talks. We've heard about the context, the patient experience, all the related national and public health data. And we also heard some initial QI work that's been done in Birmingham. So in this part of the session, Alina and I just look at how we've used all this contextual information, patient experience, and all the data that's been presented to further explore this problem at a local level, and then to develop this as a quality improvement project. Next slide, please. So the quality improvement framework helps us to continually improve the quality of healthcare, focusing on the needs of our service users. So what I particularly like about the QI framework is that it's based on a set of values and a set of methods. The values include learning from reflection, shared learning from reflection, partnership, and also collective leadership. And the set of methods include using a structured or a systematic approach or a QI methodology, including continuous measurement, understanding variation, and using plan, do, study, and act cycles to implement change ideas. So we identified a problem here from listening to our speakers, that there's a problem with poor screening for alcohol use disorders amongst inpatients on general adult wards. So we've set out to understand this problem further using a very systematic and collective approach, which is based on one of the QI methodologies called as the model for improvement. And again, this is led by Alina and her team. So she's based on the ward and they're the frontline staff. And this is by using an agreed set of QI tools and methods to test, measure, and learn continuously. Next slide, please. So as you can see on this slide, there's different types of QI methodologies. So I just mentioned one of the methodologies called Model for Improvement. I'm sure people have come across things like Lean methodology, Six Sigma, Virginia Mason, and also experience-based co-design. But for the purpose of this project, we will be focusing on the Institute of Healthcare Improvement methodology called the Model for Improvement. So at the heart of this continuous change cycle is the plan, do, study, act cycles, as you can see in the picture there. So what this framework helps is that it moderates the impulse to take immediate action, which I suppose all of us have that impulse. It provides a framework and steps to carefully analyze the problems. It gives us a more problem-focused rather than a solution-focused approach, and also helps us to test these change ideas using the PDSA cycles so that we have the opportunity to see if these proposed changes will succeed. And I think it's a very powerful tool for learning from implementation of these change ideas to see whether they work or they don't work. Next slide, please. Just briefly about this QI circle. I think the key components here, I think at the heart of this QI circle is understanding the culture and the context, which is, I think we try to understand that to some extent today. We understood the national context to this. So I think this helps us to create the right conditions for a successful project. And again, the QI cycle using the model for improvement. And I think the key here is, the patient involvement. Either, we heard about some focus groups in the previous talk, we heard about surveys. So that's some ways of small I involvement. And there's other ways of involving patients in a co-produced, to co-produce these changes, called as a big I involvement. So looking at that, and then looking at engaging the wider stakeholder group. So in the next few slides, Alina will now focus on how we looked at all these, the information that we just heard about to understand the first question that the model for improvement asks: what is it that we're trying to accomplish? So over to you, Alina.
Thank you, Deepa. Can I have the next slide, please? Okay. So in my current job as an ST4 in addictions, I have been very fortunate to work on a specialist addiction unit at Edward Myers unit in Stoke under the supervision of Dr. Watts. And I have been part of the MDT and led many alcohol detoxifications. The main learning objectives for today are to appreciate the principles of quality improvement and to describe how we want to start our QI project. Next slide, please. So the main question that we ask ourselves is how to improve the screening for alcohol use disorders for inpatients on the general adult wards. Next slide, please. It is important to identify the root causes of the problem before introducing changes. And we use the 5 ways approach combined with the fishbone diagram. We group the possible causes of the problem according to the common themes. And these themes are the referral process, the patient, training, staff, environment, and policies. And these themes are displayed in the fishbone diagram. When we look at the referral process, it's important to remember that the patient is referred for an admission to a general adult ward, either informally or under the Mental Health Act or on the Section 136. During these 3 types, any of these 3 types of assessment, the patient should be screened for alcohol use disorders. And the handover to the nurse in charge who is accepting the patient on the ward should have this information. Other important factors we should consider are the physical and mental health comorbidities the patient may present with, his motivation to complete the detox and adopt relapse prevention measures with the help of the local alcohol services. Often for patients who have unplanned admissions to the general ward, they have not had a motivational interview and they have not prepared to undergo the alcohol detox. Therefore, these patients are more prone to suffer relapse afterwards. The cultural background of the patient, their age, gender, religion, ethnicity, values, family support, they need to be taken into consideration when we are formulating a discharge plan. We have begun to talk a lot about inequalities in accessing mental health care and treatment. And often these patients have poor access to treatment, and they may be stigmatized by friends, relatives, and sometimes care providers. We can combat the inequalities by training our staff, doctors, nurses, by working collaboratively with our MDT, and further collaborate with specialists, alcohol services, and acute medical wards when it's necessary. The doctors who are clerking the patients on the general ward, on the general adult wards, may have limited experience in psychiatry and specifically in addictions. And I'm thinking here more about the FY doctors or the GP trainees. Therefore, there is a need to support them. The induction of the new intake of doctors every August and February generally, it should contain information on the clerking process and assessments, that the decision to start the detox treatment should be informed by a complete history, which should also include alcohol history, current alcohol daily intake, the audit and SEDQ scores, along with a physical examination and blood tests. Very often our wards are understaffed, and there could be emergencies related to other patients on the ward, and this could impact upon the availability to conduct of the nurses to conduct their assessments. It's also likely that it's difficult to transfer the complicated or the complex alcohol detox cases from a general adult ward to the local specialist unit, because there may not be a specialist unit available, or if it is available locally, or if this is available locally, there may not be beds available. As it was mentioned before by Professor Sinclair, the majority of admissions to a specialist unit are planned, and the unplanned detoxes or usually on our unit, they are being transferred from the general hospital and not from general adult wards. So the detox guidelines and the relevant policies should also be available to doctors and nurses, and that could be on internet or on paper copies. Next slide, please. The process mapping help us to create a visual map of the patient's journey. This tool helps us to take a step back and look at the big picture to identify gaps, bottlenecks, inefficiency, other opportunities for improvement. So if we start with the point where at the point where the patient is referred, he or she could be referred under the Mental Health Act, or maybe informally. Then the nurse has the handover from the referral and conducts the nursing pre-assessment, following which she is contacting the duty doctor, who should take a comprehensive history, including alcohol history, and use the screening tools as audit, SEDQ, if they haven't been used before. Physical examination is extremely important, and the blood tests should include liver function tests, gamma GT, albumin, full blood count, glucose, and renal function tests. It's important that the Wernicke encephalopathy is assessed, the main symptoms being confusion, disorientation, ataxia, and ophthalmoplegia, because if this is left untreated, it can further progress into Korsakoff's. Professor Sinclair has also mentioned about benzodiazepines, so I'm not going to talk a lot about this, but what I would like to talk more is about the importance of the duty doctor communicating with the day team, and the importance of the handover to the regular day team, and following which discharge planning is extremely important. The relapse prevention medication, which could be acamprosate, disulfiram, baclofen, naltrexone, looking at the social problems like housing, employment, and the necessity of further referring the patient to the local alcohol services for the continuity of care. Next slide, please. So we have identified our SMART aim, SMART aim, which is specific, measurable, attainable, relevant, and time-bound. And this is to improve screening for alcohol use disorders to ensure 100% of all new admissions to a general adult inpatient wards. In my trust, they have screening for alcohol use disorders over the next 6 months. Next slide, please. This is the audit tool, which is screening for dependence. And if the patient scores more than 20, we recommend the SATQ is being conducted as well. Next slide, please. So the SATQ is screening for the severity of the dependence, and if the patient scores more than 16, they are classed as between 16 and 30, they're classed to have moderate alcohol dependence, and if they score more than 30, a severe alcohol dependence. Next slide, please. So I involved other higher trainees, colleagues of mine, all members of the multidisciplinary team, including patients where possible. We would like to make small-scale changes and review their impact before moving on with the rest of our QI project. The stakeholders or people or groups who may be affected by our change and their engagement is important throughout all the stages of our project. We are going to do now the stakeholders analysis, and as it can avoid any conflicts or resistance to change later in the project. Our main outcome measure is the percentage of the new admissions screened for alcohol use disorders. And in order to have a better idea on what is the current percentage, we will collect baseline data on our wards, on a general ward for admissions in the last 6 months. Another outcome, as I previously mentioned, is the reduction of unplanned admissions, and planning and implementing changes using the Plan, Do, Study, Act cycles. And we will be thinking about steps to embed and sustain change. This is the message that we want to transmit to all of you. And I think we have completed the talks. Thank you for listening.
Thank you, Alina. I think the first grand round session has kind of exemplified how an opportunity for change or improvement can be examined using local and national context, data, the patient experiences, and all this, how we can use all this to help synthesize a change project to address this evidence practice gap at a local level. So thank you for that. Over to you, Raoof.
Thank you, Deepa. That's excellent. Thank you, Deepa and Alina, for giving us an example how an established methodology can be used to identify a problem and to drive a change. I think that is the whole spirit of this grand rounds. That's what really want to happen. I can see, looking at the names, I can see a lot of trainees I know spread across the country. So I'm sure Deepa and Alina would have inspired you to sort of look at some local problem and identify a problem and drive change through a QA project and make a real difference to the patient care. And as Subodh said, right, translating evidence into real change in patient care. So thank you. And now we have about 10 minutes to answer any questions. I know that must have been a long day for many of you after work. So some of you already left, but excellent. So over to you. So as you know, you can post questions on the chat and the panel members will try to address that.
Raoof, is it worth just saying a little bit about, because I've been looking at the chat and I've been trying to answer things that aren't particularly, because obviously I think one of the challenges we have is that there are so many places that we could start. As Deepa was saying earlier, you know, I think sometimes there's a real challenge that you can think there's so much to be done. It's all impossible, so let's do nothing. And I think part of this QI project and what we're trying to do is kind of say, well, let's start somewhere. And one thing is, if we screening, one of the things that Alina's suggested, and great talk, thank you, Alina, and is that sense of actually, if we start with screening, I think it builds people's confidence. B, it kind of just demystifies it a bit and helps sort of normalize it and destigmatize it. And some of the questions in the chat have been talking about that. So I think that is key, and that's what I think we're going to be to be looking at. But just because some of them have been about the management of the thiamine, is just to say that essentially in patients who require an inpatient detox, it is something that really their risk of probably having Wernicke's is really quite high. And so really parenteral thiamine is something that you'd be looking at, and then following it up with oral thiamine. And obviously in many psychiatric units, you're not going to be using intravenous, but there's no reason not to use IM. So I'll leave that there. I think you're muted, Raoof.
Sorry, no, I'm just saying that it's a really important point, and it's very relevant to the clinical practice. I don't know whether Zafar is still around, whether he wanted to make any comment.
Sorry, sorry, Raoof, I missed the question.
No, I just wondered, sort of listening to all that, do you want to make any comment, any sort of message to everyone in terms of taking this forward?
No, I mean, I think it's just that message. I mean, I can see a lot of the message are around the preventative element of it, and it's beyond what you do with kind of individual patients. And I think we do need to work together, between the two faculties. And I know Subodh did a fantastic presentation locally on public health and inequalities. And, and if we're really serious about population mental health, and I think in terms of the well-being of our local populations, then I think we could form a really, really powerful alliance around that.
Absolutely, yeah. Thank you, Nat. Do you want to say anything about the challenges you faced locally and what others can learn from that, Nat?
Yeah, and so Kerry and Dr. Rowena Jones with me as well. I think in addition to what was in the slides, I think somebody's just put it into the chat. It's just making it clear that it's everybody's business. I think that's the key message. And absolutely. I think if you listen to lots and lots of service users who might be in any part of any trust, whether it's forensic, perinatal, CMHT, whatever it is, there are so many examples of when people feel able to share their experience. It's been a bit rubbish, not everyone. Some people have had great experiences, and we just all need to work together, and we can make a real difference. And it's not about criticising, it's just about, this is the benchmark, what can we do from here? So I think, like I said before, I think the QI approach really breaks it down. And I don't know whether my colleagues Kerry or Rowena, they're both absolutely sharp-ended in acute inpatient services. So that's where the challenges are, I think.
I would just like to add to that. I think in acute care, what we're really trying to do is get a culture where we're really recognising alcohol problems and drug problems and becoming much more proactive. And it's multi-pronged. So we're trying to bring our consultants together more, because it's not just about our trainees, it's about our consultants and getting their expertise up to date. So we're having more meetings with a sort of a peer group that we've established. We're focusing on our physical health protocols so that it's really set in stone what's expected of junior doctors when they're doing clerkings of patients in terms of physical exams, etc. Because our experience in Birmingham is very much in line with the POM audit in the deficiencies in particularly physical exam and cognitive assessment. I think we're not doing enough of for people with alcohol disorders. Another thing we're just trying to do is improve our knowledge of the guidelines and get them used more. And it comes down to things like we've got electronic notes, so we're doing a project at the moment to try to get our the SIVA scales and other opiate withdrawal scales, so that they're actually on our electronic notes, so that people aren't having to go printing them off the internet and bringing them up to the ward to fill in. So I think it's multi-pronged, and it's work in progress.
Yeah, thank you. Kerry, do you want to add anything to that, Kerry?
Thanks, Abdul. I think I probably just really want to underpin what Nat and Rowena have both said. Actually, I think that I'm probably in a slightly different position here, in that I'm a mental health nurse with a long background in addiction, but in recent years been working back in acute mental health. So it's interesting coming back round full circle, and it resonates so much with what I've heard today in terms of the experiences I've seen. And as Rowena says, I think the POM audit absolutely underpins where I think we are. I would probably really underpin Nat's point, which is that, yes, it is very multifactorial, and you can kind of think, gosh, there's so much going on, where do we start? But I think it is that thing about taking the first step. And so the first step is probably about just having the conversation about it, just finding the right clinical forums to be able to actually add alcohol as a title to the agenda, and then start having that conversation about where are we. And we can use the POM audits just to identify that there's a conversation to have. And then I think if we do then get the right people in the room, and whether that's our postgraduate doctors or senior doctors and others, pharmacists, coming together and having those conversations about where are we at with alcohol in acute mental health. I think that's really important. So it is about using that framework that Nat's talked about, and just getting on board really and giving it a go. And I think what I would say as well, with a different hat, having worked a lot in hospital alcohol liaison with physicians, I think that a few years ago, I saw certainly here in Birmingham, physicians sort of saying, well, alcohol's not kind of really our thing, and we'll kind of get you specialists in to come and do that. And actually, I think that's really come full circle now. And actually, when I look in, particularly in gastroenterology and hepatology, you look at how those doctors have really embraced alcohol now, and you look at the quality of some of their assessments and consideration, and mental health, psychosocial addiction assessments. I think they're excellent, and I think they've just adopted the culture of saying this is our business, and we do need to be part of this. And I suppose for me, I'm just trying to work out how we can, in acute mental health and with psychiatrists, how we can do the same. But I think the one last point I would say is that what was really encouraging for me is that Nat and Rowena and Ed helped pull together a while ago an away day for our acute psychiatrists on substance misuse issues, and it was really, really well attended. Everybody who's often too busy to get to so many meetings all came along and said, actually, we need to know more about this, and we need to have more of a conversation. So there is part of it that's saying, I think we're knocking on an open door, and we probably just need to use this framework to try and drive the conversation. But I don't think it can be a one-off conversation. I think it's something that needs to continue to come round and round and round continually. Thank you.
Yeah, thank you, Kerry. That's really helpful. That's exactly the summary I wanted to say. I think it's a real translating that evidence base into changes in local practice. Okay, so thank you, everyone. I just want to thank everyone for this, all the panelists and all your contributions, and especially the addiction faculties, the West Midlands Division, and Deepa and Alina. And most importantly, Gemma. I think that is the key. We all need to remember when we are thinking about change making in any area. It's really, really, really important that we listen to people with lived experience. And also in the chat, I can see a lot of ideas and about the other clinical issues, the faculties and divisions working together. So really, I think we really want to take this forward, and we are planning many more grant rounds to address specific issues. So please use that feedback link to make your suggestions how we can make it even better. Catherine, anything else we need to remind everyone about certificates or anything? Catherine?
No, thank you. That's it. Just we'll be sending your certificates over the next week, and you'll be able to see the recording very soon, and we'll let you know once that's ready.
Excellent. So thank you very much, Catherine and team at Calc as well. So thank you, everyone. Have a nice evening. So thank you.